Welcome. I am Delaware State Representative Paul Baumbach, and it's been a while, but it's time for an update on Delaware retiree health benefits. And these are updates I've been doing a bunch, and then I took several weeks off, and so we're a little bit overdue for an update. I also record this; people can catch it afterwards, and we will see how that goes. If anyone can just comment if you can hear me, that would be really helpful. And with that, I'm going to start on some of the material that has come out since the last update. So bring this, I need to bring present, share screen, and we bring that guy in, allow it, and there we go. Good. Okay. All right, Lynn, thank you very much. So I think the last time I did an update was on April 30th. So we've had 2 or 3 meetings since then. So let's just go through some of the presentations of that point and see where it goes. So on May 8th, we met, and you can see the beginning of the slides here, last disclaimer, describe what OPEB is, and that's everything except a pension that the state is responsible for retirees. So it's other post-employment benefits and other means other than pensions. So it's, you can see healthcare, life insurance, disability, group legal, long-term care, but the focus really is on healthcare. And this is both for retirees who are not yet 65 years of age, so before Medicare kicks in. And then once you're of Medicare age, then it's the Medigap or whatever we supplement, whatever we help you with along with Medicare. Lots of history. I don't want to go through this stuff, but there's different ways. So we've made promises for retiree health benefits, and we haven't set money aside for that. So that the gap between the promises and the money set aside, we'll call it the trust fund balance, is a gap, and that's an OPEB liability. Different ways to address it is you can reduce some of the benefits. You can put caps on things. You can also restructure it to have it, instead of giving you a policy, rather give you dollars to purchase your own policy. You can purchase things on an exchange instead of the state providing it. Funding strategy is a big piece, and that's just putting more dollars into the trust fund. And the other thing is we can just stop providing it, full exit. And even though it's listed here, please do not interpret that as meaning that people are talking about that. That is not really under discussion. So some definitions of Medicare and history. One of the big parts here is people said, how did we get to an $8.355 billion gap? And the reason really is that there were accounting rules that changed. They changed earlier for pensions than they did for retiree health benefits. So over time, especially in 2016, this gap became much more visible, and therefore states had to really start addressing it. Still, you can say 2016 is 7 years ago. It's taken us a while to get to the point of saying we really need to deal with it now. And that is all of that presentation from May 8th. So let's go forward 2 or 3 weeks to May 19th. And this is reviewing HRAs. So we've had, a whole bunch of different ways of looking at plans. One is just doing the Medic Fill, which is really a Medicare supplement. That's the current plan. Most people are aware, the administration proposed a switch to a Medicare Advantage plan, which really, I'll say it backs out normal Medicare, replaces it with this other system that uses the same dollars and tries to be a full system. But there are real challenges with it that came up, and there's lawsuits and all that sort of stuff. But a third approach is using a health retirement account, and that's one where the state gives dollars to the retiree purchases their own plan. Let's go through here briefly. I was at one point a little bit enamored with this, mainly because of a design from the state of Rhode Island. I will go into that in a bit. There's a lot of details, but I want to really go to the high level points. So the employer sets up the HRA, retiree gets the expenses, submit the expenses, and then gets a check for the for what the expenses were, as long as they're qualified. And you can, how do you get it? You're going to enroll directly with a Medicare system, and whether you go completely independently or through some help, we'll see. Most likely, if the state did this, the state would provide that middle person to work with you to help you out with that, sort of a navigator, if you will. And different roles of what the sponsor would do and what the state would do, et cetera, and what the retiree does. But I want to really jump through benefit advisors. Think of them as navigators, people who are helping people through all the selection process. I want to really jump to this slide. This is the most important slide in my mind. So notice this all starts at age 65 because an HRA is really, in this case, designed for to be used as somebody who's eligible for Medicare. It goes out to age 90 and beyond. And what you see is that what the cost of the plans is in blue, the out-of-pocket costs are in orange, and then whatever is excess. So here, this is looking at a $5,000 a year at the start, and it goes up 2% a year. I think that's correct, $5,100, and then it goes up 2% a year. So what you see is a typical 65-year-old would not incur $5,000 of cost, maybe $3,000, $2,000 is left over, and then so it adds to the balance. The balance keeps growing. That's what this gray is the unused health reimbursement account balance. And what you see is that the average retiree has their costs go up, and frankly go up faster than what the amount that goes into the HRA. And the HRA is what this red dotted line. So you can see the cost somewhere around age 79 in this case. It starts meeting and then exceeding the level that you get into your HRA, which means you start drawing down the balance. Well, how much excess is there keeps growing and growing. And by the time you're 85, 86, you're starting to cut in and even eliminate your HRA, which means you're completely out of pocket. So from 87 on, this excess of several $1,000s is completely on you. So I look at this and say, this can be beneficial for people in their early years. It's something that you cannot start for somebody when they're 75 because it assumes that you have from age 65 on many years of building up excess balance. So you can't start someone partway through. And the second thing is if you've got a low increase in the annual contribution level, then that is not going to keep up with expenses. And the typical person when they turn 85 or so is going to start being out of pocket. And this also doesn't really look at those who have the highest medical costs, those who may have a lot of pre-existing conditions, in which case you would cross that line and you would exhaust your HRA at an earlier age. So this may be fine for the average person who lives an average amount of time, but people who live long, people who have higher medical expenses, I think is a problem with this kind of assumption of $5,100 a year with a 2% increase. So, but this is traditional. It's not the Rhode Island plan, but I think we'll look at that in a bit. I think we will. So I'm going to come down here. Okay, so now we're jumping over, and we're gonna spend some time on this kind of slide. So we've looked at 3 different categories of ways to address the OPEB shortfall. And one is funding, and one is changing who's eligible and how much you're eligible for. And the third way is changing it's known as the plan design. So we go into Medicare Advantage, we're giving you an option to get to Medicare Advantage, or are we switching over to an HRA, you purchase it on your own, just go in traditional Medigap, or are we just going to keep doing our MedicFill? So those 3 are funding, eligibility, plan design. So here's eligibility. For some reason, this slide is only presented with 3 of the 4 that we've been talking about. This is not the one where you're not eligible until 55 or 60 years of age. We'll get to that later on. So we can increase an amount that a retiree has to pay to have their spouse covered. That's one thing we could do. We could increase how much the retiree pays, or decrease how much the retiree pays based on years of service, and extend it compared to what it is today. Don't ask me what it is today. I think it's 15 years for 50%. And this would extend the wait to 20 years to get to 50%. And then the one thing is if you leave employment and may presumably, but not necessarily, go to a different employer, but you're well under 65, you're not getting your pension. Right now, you're eligible for health benefits. This says, no, you wouldn't if you leave before you're eligible for your pension. So it's known as term vested. I hate that phrase. I don't think it really says much. But when you look at all these things, these all seem to get you somewhere around, and we'll call it 19, 20% in any of these approaches get to about 20% of the gap being filled. And keep a pin in that. We're going to keep coming back to this, and we're going to be very painful when we look at this for the most recent meeting from Monday. A and B here are different models, different ways of figuring out how do you grandfather. Does this change, does this proposed change only affect those who are hired in the past for 10 years or have been working for 10 years or less, or only those who haven't retired until 2025? Those are the two models we've looked at. We will be looking at a third model shortly. But really, regardless, you're still in that 18 to 20% of the funding ratio gap being addressed here. I want to briefly and very vaguely mention there's this row up top, baseline. If we do nothing, we have not available as far as what our funding ratio is, who it affects, and what the approximate dollar of the liability reduction is. We'll get to that in a bit. That's all I want to go over from that presentation. So let's advance to the most recent meeting. So let me see what the three are. We'll get to that in a bit. Right, June 5th. Okay, let's go June 5th first. And what are we at? The 10th. So what are these other guys then? Well, let's go to this one. Some updates on the group health system. So the State Employee Benefit Committee, the SEBC, met in March, and it said we were really not charging enough for just the straight healthcare we provide, both to employees and to retirees. And they proposed that everyone originally they said everyone would have the cost go up by 9.4%. Then they backed off, and the March meeting said this is only for non-Medicare recipients. And one of the reasons is when you look purely at Medicare retirees, what you find is that the dollars attributed to that more than cover the cost of them. And the reason is a Medicare age retiree is having 80% of their costs covered by Medicare. So what the state's responsible for is just that last 20%. So it costs much less than either a current employee or a retiree who's less than 65 years of age. So there are different costs. The populations have different costs, and yet we've been assessing, we've been calculating the quote premium at around the same level and having increases be uniform. So they said, you know what, we shouldn't do that. We should make it 99.4% for these the two subgroups of current employees and less than 65-year-olds. But then in May, they voted to increase the Medicare age by 5.0%, about half their increase of the younger two cohorts. And that's better. So, and do keep in mind, the populations have different anniversary dates. So Medicare age people have their plans change as of January 1st of each year. Current employees and also retirees under less than 65 years of age have their plan year start on July 1st, just to keep things nice and complicated. What else? Prescription changes were made in there, including copays. There's some increases in there. So you've got it. It's really, this is not all that, this part is gory detail, but not as important as the rest that we're going to get to. They gave an update on the lawsuit. So a group called Rise Delaware formed in the second half of last year after the proposed change of forcing anyone who's a state retiree of Medicare age who wants health benefits from the state, they'd have to get it through a Medicare Advantage plan that the state had arranged. And a group called Rise Delaware sued the state and said that wasn't properly done. And a judge, Calvin Scott, ruled that the lawsuit should indeed stop the implementation of that change. So it's been on hold since October. So that was a preliminary order. A final order was issued a few weeks ago, about 3 weeks ago. And they said that, what do they say? Well, the important part is it's moving on to the Supreme Court. The issue of fees or in Chancery Court. The bottom line is that the response to the two parties, the state's already filed a brief. Rise Delaware is filing their brief about 4 weeks from now. So then presumably the Supreme Court has everything they need to come up with a decision later this year. Nothing more really to be shared at that point. Okay, so so we asked for a whole bunch of models. So let's start with the funding. Remember, 3 categories: funding, eligibility, plan design. So we look at it, and this is going to be, we're going to notice a few things. So first come down 1%, 2%, 3%. This is of the budget, which is roughly the state's annual operating budget, roughly $5 billion. So 1% of that's $50 million. And so the 1% additional funding says the state will put 1% of the budget every year into the OPEB trust fund. It's not called that, but I'm going to call it the OPEB trust fund. And that will increase as the budget increases, 5 million this year, 5.2 next year, et cetera. Then we go from 50 million to 52 million, et cetera, et cetera. That's how it works. And what it says is if we were to do that, then the projections over 30 years is that we would fill about 60% of that gap. And if we did 2%, we'd be up to 93% of that gap. So you can look at this and say, the only thing we do is do funding, we can get, our goal should be somewhere in the 75, 80% range. If we do somewhere around maybe 1.5%, that alone, certainly 2%, that alone will do all that we need to do if that's the only change we want to make and we want to get the funding level up to a good level. It'll take 30 years, but we will be on a path that sustainably gets us to that point in a steady manner. But if we take 1.5% of the budget, it means $75 million a year is reserved for something that won't be able to be used to provide other services for our state. So it's it's challenging to get legislators to say we want to do 75 million less of annual services for people. So the 1% is going to be an easy one, and not an easy one. We have language. We have a bill to file. And to propose a 1%, that will get us about 60%. And we've been generally figuring we need to use some of the other avenues of eligibility and plan design to get us most of the rest of the way, but that gets us to 60%. I do want to draw your attention to this first line. So our baseline, this is our steady state. This is where we are today. We fund, the state funds, not the employees, the state funds through payroll, 0.36% a year of payroll. That the current balance in the fund and that level of ongoing funding will, in and of itself, have us funded at 17.8%. That means that the 1% isn't giving us 60%, it's actually giving us 42% because we're already on pace to have 17.8, we'll call it 18% covered. So the next 42% we get by doing the 1% funding. Remember that, 17.8%. Why does that matter? Well, it's really close to the figures on this slide. So these are the eligibility changes we looked at: reducing the spousal state share, increasing how much share, how many years you need before you get a higher costs covered by the state, having this term vested thing, or raising the minimum retirement age. Let's look really closely. Let's round. Let's get rid of the tenths. 18% is our baseline. If we reduce the spousal share, so you have to pay 50% for your spouse to be covered. Model A is if you have less than 10 years already with the state, so you still going to work another 10 or 20 years before you retire and get your pension, get your health benefits. If we do that, that's only going to change things by 1%, from 17.8 to 18.9, or from 18 to 19%. The most you get is Model C, and that's future retirees, people who retire more than a year and a half from now. That gets you a whopping 3%. Okay, so it's the least generous grandfather path for this one step of how many years you have to wait before the state will pitch in 50% or 75% or 100% of your premium. And all that gets you is 3%. It's not getting you 20%. We are already at 17.8. So any of these, even if you took 2 or 3 of these together, you get maybe 8%, maybe 7%. We start at 60 once we get the 1% funding. Okay, that was the previous slide, remember? We're at 59.8, we're calling it 60% by doing 1% of the budget. Cool. We got to get at least 15%, maybe 20% more. These guys, that's a rounding error. 1%, 2% at most, 3% at most, actually. But these are hard ones to do. Frankly, the one employees were surveyed, and what they said was, of the changes that were being thrown at them fast and furious, the one that they were least offended by was this waiting until age 60 to get your health benefits, or 55 if you're a retired state police officer. Even that gets you a 1.5% max improvement. So that gets you from 60 to 61.5%. That's close to a rounding error. It doesn't move the needle. So what we heard on Monday, it's the first time we've heard this, and we're 4 months in, and I'm mad, is that we're already at 18%. These changes get you to maybe 19%, maybe 20%. So if we get the baseline plus the 1% and we're at 60%, this is going to get us to 63%, 64%. We're not closing in on 80. I was really frustrated here because up until Monday, we were told these things can help you close in on 80%. That was wrong. We were misinformed. I'm still digesting this, and I'm still upset. So let me go to the next slide. So these are the plan designs. Remember that HRA, that nice graph that goes up and comes down, and you build up a balance, you use up the balance, then you're out of pocket for thousands of dollars a year. So this is what they showed us, that 2%. And that gets us from that 17.8, we'll call it 18%, up to somewhere around 26%. So that gives you about an 8% improvement. That's an improvement. But remember, that hurts people who live a long time. That hurts those who spend above average for health costs. If you increase it by 4% a year, which is actually a lot closer to the Rhode Island plan, not only don't you get any progress towards funding it, you at best maintain 17.8%. And at worst, you make it even worse. You get a bigger hole. So even Medicare alone, unchanged, is better than switching to an HRA with a 4% annual increase. So either we hurt our retirees who live a long time or have high health costs with that 2% thing, or we make no progress on the funding gap, the OPEB gap. Two losing propositions. So this presentation of choices in design are bad. They're not helpful at all in my mind. So then we're back to eligibility changes, which is really small, 1.5%, 2% per. You put 2 or 3 together, maybe you get 6%. So we go from 60 to 66%. We're still well short of 75 or 80%. And so what we've seen, the only thing that I think really gets us meaningfully there is doing more funding and getting us probably more closer to a 1.5%, which, somewhere that should get us to 75%, thereabouts, 1.5%. But that's a bigger ask for 1.5% versus 1%. But the slides we got on Monday, especially with this first line telling us what our baseline was, so that the delta that these changes were giving us, 0 for a 4% HRA, 8% for an HRA that is not good for people who live a long time, not really great. So that was that. We got hit in the face with cold water on Monday. So what do we have ahead of us? We've got a bunch more meetings, back to 2 a month. Our next one is on the 26th, and we want to figure out, are there any more things we want modeled? And then we start combining, saying, well, if we do funding plus this, what does that look like? Funding plus this, what's that look like? Because these are not additive. If baseline plus funding is 60%, and then we add something that seems to be a 4% impact on its own, it may only give us 2.5%. So we may only be at 62.5%. So we do need to model combinations. We've not done that yet. We're going to identify what we want modeled, and then we're going to see what the impact is. That's the July 20th and the August, and July 10th. Then we've got our menu. And says, okay, we got so much here that we can choose. What do we want to do on funding? How far do we want funding to take us? What combination do we like? Actually, what we plan to do on June 26th, our next meeting, is figure out what things we want to roll out. So if we come back here and we say, okay, do we want to roll out 3%? Because that would get us further than we need. And that's reserving a heck of a lot of money. Let's just take that off the table. Now, these things are just giving us 1%, 2%, or 3%. Are there any that we just want to completely rule out because we're going to piss off people and get next to nothing? So we may say, that we're getting less than 1% from Model B, here, and it's just not worth making a change that gets us less than 1%. So we may just pull out. We may pull out everything here under the term vested is less than 1%. I'm going to say it's not worth pissing people off to narrow the gap by less than 1%. You got to get some benefit from this thing. So when we meet on the 26th, we'll be discussing, are there options? Because we got a zillion options. Can we roll some out? And by rolling them out, we can simplify how many combinations we need to do. So that's what we'll be doing on June 26th. What more do we need modeled? What combinations do we need modeled? And let's eliminate some choices. That has a potential, one choice, and we're going to keep talking about it. We may say, we do not want to see Medicare Advantage at all. Or we may want to say, we want to see what having Medicare Advantage as an option, and then Medic-Fill or Medigap thing like Medic-Fill as an option. And if there's a difference in price, does any of that get passed on to the retiree? What proportion of it? Does it depend on years of service? It depends on when they retired, et cetera, et cetera. I will say, when you look back here at all these models change nothing for anyone currently retired. The most that we would do in what the scenarios we've examined are ones of people who retire less than 2 years from now, at the end of 2024, end of next year. So we are not considering, we've not yet considered anything that would affect anyone who is already retired. So it's not that we can't consider it, but we have not yet. So I really want to make that plain. There's a lot of reasons to be concerned because of how everything went down the last 2 years and how we got to the point of the state proposing a Medicare Advantage forced on our state retirees who are of Medicare age. But the subcommittee that I'm a co-chair of has not considered anything that would force anything on current retirees, and actually nothing even for those who retire this year or next year. Okay, I have gone through that part. Let me just see if there's anything else. What is 2 and 3? Do I know this stuff? Okay, that's old stuff. That's old stuff too. Okay. Oh, these things I want to look through. We looked through all that stuff. Oh, did we look through that? It's good enough. All for both. Okay, resume discussion. That's all fine. I think we covered enough important stuff. Do we need to worry about that? No premiums. Yeah, lots of details on that stuff. Oh, but let me hit on this one. This is an interesting slide. So OEC, we love our abbreviations. Other employment costs. So when we say we're going to add one person, a staff member for parks rangers, we know what the salary is. We know what the healthcare cost is. What are the other employment costs? Well, we contribute towards the pension, about 11.5%. And then the employee pays a little bit also. They pay about 4%, depending on their income level. Disability insurance, the state pays some for that. Post-retirement increase, that's because the General Assembly periodically gives an increase to the pension. Not every year, not on any kind of schedule, but occasionally we do. And that costs money. So we set money aside based on payroll for future post-employment increases. Then we have this whopping 0.36%, a whopping $180 per employee per year that goes towards pre-funding their retiree health benefits. That is a rounding error. That's just a smidge. At one point, it was 0.9% for several years, then got cut back during lean times. But even that would be $500 a year, so $450 a year. So a very small amount goes in there. We set aside from current employees money to pay for current retirees. So it's a pay-go. Our current retirees, we haven't paid ahead of time enough money for them. So those costs have to be paid. And part of it is apportioned, is allocated to our current employees. And each department that employs current employees sets aside 9.21%, and that goes to our current retirees. A little bit of a shell game going on. And then the state pays Medicare, FICA, workers' comp, unemployed insurance, and then also the employee pays the employee portion of Social Security and Medicare. So, roughly, we pay somebody $50,000 a year. We also give them health insurance, maybe worth another $10,000 a year. So that's up to $60,000 a year, and then another 31%, another $15,000 a year, or more, $16,000 a year. The state pays for these other things. Just point it all out there. One thing to notice is retiree health, pre-funding your health care, post-retirement. The employee pays nothing there. They do pay towards their pension. The pension is a legal obligation from the state to the retiree. The fact that the employee pays it during their work years is another reason why it is an obligation. It is not. It isn't, and it is, and it's a benefit, but it's also an entitlement because they paid for it. So a portion of the money in the pension fund came directly from the employees, and that is a legal obligation to the employees. The employees have not paid towards retiree health. All the money thus far that's gone in there has been from the employer, from the state. I say that, and I just lay it out there, guys. The state does not have an explicit legal obligation of providing retiree health benefits. We have you can argue a moral obligation, but not a legal obligation. Importantly, if we took money, if we charged money that came out of employees' paychecks from their side, not from the state side, that would introduce a legal obligation for the state providing retiree health. So if we charged 2% a year, so that's $1,000 a year to an employee making $50,000 for their retiree health, then they have the legal right to demand retiree health when they retire. Because we've got zeros from the employee historically, for all retiree health, it is something that the state's done some reserving money for, but it is not something that is a legal obligation. Again, I've heard that it is a moral obligation, and a court may say that moral obligation is strong enough, but there's not a legal explicit obligation there. So anyway, throw that out there. But some people, including me, have said, well, we should boost OPEB, the employer rate, from 0.36% up to 1% or thereabouts. And the bottom line is it would hardly move the needle. It would be another positive change, but a small one. And with that, I'm going to see if there's questions, and I'll do my best to field any questions. Just type them in if you have any questions. You see my email address. I can follow up later. If you follow up with questions, I can do my best to get answers to you. But I'll sort of go over the bottom line is we have several meetings ahead of us, and we're going to be looking at reducing some of our choices. But with what we just learned on Monday, the eligibility changes are going to provide a much smaller role in filling the gap. We may need to do more in the way of funding. And we may need to look at other things such as having future retirees switch to something. So let me back up. Our Medic-Fill program is really patterned after a Medigap, Medigap version F or G. Provides out the same benefits, very little out of pocket. We can design it after Medigap programs that have a lower level of benefits, a higher level of out-of-pockets. And we can do that for, let's say, people who are hired after January 1st of 2025. And that can do some savings down the road. Whether that addresses how things look in 2025, it may be small if it's only for future hires, and let alone the 30 years until they become a retiree. But at least down the road, way down the road, it's going to be beneficial. So that may be a change that's worth doing now. We are looking at the long term, but we're also looking at how do we get on a firm path to get us substantially addressing the lion's share of that gap, that $8.355 billion gap projected for 2052 for OPEB. Okay, next meeting is June 26th. I think it's the afternoon. Everything's posted on the state's website. All the materials are there. There is, I should say, Rise Delaware is coming down to Legislative Hall on Tuesday, midday. And that's about it. Okay, Roger. With the small contribution of the proposed future retiree changes, it appears that this will boil down to a decision about increased state funding and future retiree contributions. Is that how you see it? It's a good question. So, Roger, I'm going to go back to the slides. Okay, there we go. Okay, back one. Okay, so how do I see it? And I spoke with some colleagues earlier, I guess on Thursday, and I presented the same stuff I just presented to you, and especially the hey, we got hoodwinked. We thought these eligibility things were going to really make a big difference, and they are not going to make a big difference. If we can't get much out of eligibility changes, we can't squeeze more out of that. It's not that we're going to abandon it, but we're not going to do much with eligibility changes. So that means that where do we go? There we go. So that means we're going to be looking at funding. We already are ready to implement the 1%. Senator Townsend and I, Senator Pettyjohn, Representative Mike Ramone, the 4 legislators on the Retiree Health Benefits Advisory Subcommittee have already crafted the legislation to do the 1%. Roger, my best guess is that we do the 1% now and next year. And the subcommittee may, in its October 1st, actually may try to make a September 1st recommendation, recommend 1.5% or even 2% in there. So that wouldn't floor me. I think we're going to have robust discussion about plan changes. And that could be one where right now, those who are hired after 2012, July 1st, 2012, I think, pay 5% of the share during when they're of Medicare age, and the state pays 95%. I can picture for new hires moving that to 10, 15, or even 20%. We don't want to change. Sorry, some of us do not want to change it for any current employee. We don't want to have implied / promise something and then back off on it. But I think that if we decrease the state share for some set, and whether it be all future hires or those who have been working less than 10 years, something like that, I'm hopeful that could be a 5% or maybe even a 10% increase. But we need that modeled to answer that. But that's a future retiree contribution, as to your question. I'm sorry, the question is, given the small contribution of the proposed future retiree changes, it appears that this will boil down to discussion about increased state funding and future retiree contributions. Is this how you see it? I should have given you a simple answer. Yeah, I think that's the most likely path. But we're going to need to wait and see how our discussion goes on June 26th and beyond. But that seems likely as of right now. I'm still digesting this darn baseline being already at 17.8%. So all the numbers are inflated by 17.8% versus what we were thinking. Nancy, you are most welcome. I don't see further questions. Sort of last countdown. If you have any further questions, I will likely, I may wait until, it may be a while till I do another update, because we're in crazy month now, our last 3 weeks of session plus a day. And Nancy, I'll look for your email. So it's really tough to find time to do these, but I'm glad I had some time today to do this. Please don't hesitate to reach out to me by email if you have any questions. I will do my best to respond. And I hope that's good for now. I do want to thank you for your time. I will save this, put it on YouTube, so even those who don't use Facebook, believe it or not, lots of people don't use Facebook, it'll be available to watch on YouTube. You don't need an account on YouTube to watch it. And thank you for your questions. Thank you for your time. Please have a wonderful weekend. The weather is wonderful. I think the smoke's out of the air finally. So you take care. I'm glad you joined us. Thank you.